Hi, my name is Zoe Fanning, and I'm a recent graduate at Boston College, where I majored in international studies with concentrations in ethics and social justice, as well as a focus in global health, and I also received a minor in public health. Before I get started, I would just like to say a huge thank you to the Center for Human Rights and International Justice at Boston College for their generous grant towards my thesis research, specifically towards my interviews in Geneva, Switzerland, which helped to not only kickstart my thesis research, but also helped to open my eyes to what I hope to dedicate my career to. My thesis was titled Civilian Health Under Fire, International Healthcare Intervention in Post-Cold War Armed Conflicts. And I spent about a year working on this thesis under my incredible advisor, Professor Jennifer Erickson of Boston College's Political Science and International Studies departments. So, for a little bit of background, about 87% of deaths from political violence are civilian non-combatants, and this figure has been increasing in the last 70 years or so. And civilian health is really impacted from all sides of conflict, specifically or most obviously with regards to depletion of the healthcare system and healthcare resources, but maybe less obviously with regards to the impact on food and water, shelter, education, employment, and just security in general. And because the government of the country in conflict is often a party to the conflict, they are therefore either often unwilling or unable to provide those services to the country, which is where the role of the international community comes in. So this includes other outside governments, international organizations such as the United Nations, and non-state actors, mainly non-governmental organizations. So my thesis sought to explore why there is variation in the international community's response to health crises in international conflict, and what variables are impacting that variation. And I mainly focused on post-Cold War armed conflicts for a few reasons. Because the ways in which wars are fought have changed dramatically since then, because of the observance to international law and how that has changed, and finally because of the change in the landscape and just general scope of conflict. Additionally, internal armed conflicts or intrastate conflicts last about 3 times longer than they did before 1980, and they last about 6 times longer than interstate or international armed conflicts. And this is especially troubling for healthcare. So there were 3 main components to my thesis, all which provided a different perspective on this research question. The 3 included geospatial mapping, statistical analyses, and 3 case studies. And as I mentioned earlier, the Center for Human Rights and International Justice helped to fund my interviews in Geneva, Switzerland, which informed all 3 of these aspects. And I conducted these interviews back in June of 2019, where I spoke with a little less than 30 people with different roles and different levels of expertise at international organizations in Geneva, a number of non-governmental organizations, and a number of people at academic institutions in Geneva as well. And these individuals had expertise in either conflict, health, or a field that meshed the 2 together. Some of the fields that I found especially interesting included landmines and landmine action, emergency response and planning, and political conflicts. And these interviews helped to provide in-depth analyses of conflict processes, as well as the role of politics, healthcare outcomes, and the specific role of the institution that I was interviewing with in responding to health crises in conflict. The first component of my thesis that these interviews helped to inform was my geospatial maps, which aimed to provide a visual representation of the person, place, and time of conflict, specifically by mapping armed conflict events, healthcare needs and healthcare availability, population and migration, specifically internally displaced populations, and where available, I tried to map aid flows to show whether one portion of the country was receiving a disproportionate amount of aid as opposed to another portion of the country. And these maps helped to reveal the extent of both armed conflict and of health needs, as well as the necessary international response to help remediate those needs. The second portion of my thesis that the interviews helped to inform were my statistical analyses, which aimed to quantify the relationship between armed conflict, civilian health outcomes, and the international community's response or interventions. And I did so by controlling for a number of factors, including the gross domestic product of the country, or the GDP per capita, human rights violations, the regime type, the infant mortality ratio, the military spending of that country, and, where applicable, the population size. And the final component of my thesis that these interviews helped to inform were my case studies, the first of which was of the Bosnian War, which occurred from 1992 to 1995. It was really a case of when humanitarian and health interventions are used as a treatment of the symptoms of the conflict, rather than an attempt by the international community to stop the ultimate cause or exposure of the conflict. And ultimately, the Bosnian Civil War revealed that despite the novelty of the conflict being just after the Cold War, despite that novelty, despite access and security issues, and despite an impossibility of impartiality, that the ultimate targeting of civilians really pulled the international community in to help assist with humanitarian and health needs. The second case study was of the Nepal Civil War, which lasted from 1996 to 2006, and was an example of an enabling environment where both parties to the conflict, both the Maoist rebels and the government itself, actually encouraged the building up of healthcare infrastructure because they valued health and they understood the importance and the power that a healthy population had. But this also was an example of a case where, despite the costs of becoming involved in a violent situation, that the civilian health need outweighed those costs and encouraged the international community to become involved. And the final case study was of the Syrian Civil War, which began in 2011 and is ongoing. And this case study really revealed what is emblematic or true of all international responses to health crises in conflict, in that there are paradoxes. That because of these huge costs to becoming involved, like those that I previously mentioned, as well as attacks on healthcare personnel, which have really become a hallmark of the Syrian Civil War, devastatingly and unfortunately. Despite these huge costs to involvement, the Syrian Civil War has seen record-breaking international involvement and funding of health responses and health remediation. So ultimately, these three components of my thesis revealed that despite these massive costs to becoming involved, that there is a strong international norm or international obligation of responding to health crises in conflict, especially when they involve civilian populations. So the greater the health need and the smaller the cost, the stronger the international community's presence. And I find the results of this thesis to be somewhat encouraging because they show that the international community is willing to assist in maintaining and building up the health of civilians that may not be their own. And it is my hope that this apparent norm can continue to be both strengthened and refined, and that specifically civilian involvement in conflict, but more broadly conflict in general, will ultimately cease to exist. I would once again like to thank the Center for Human Rights and International Justice not only for their generosity towards my thesis, but also for the incredible work that they are doing to study and work towards fulfillment of human rights and global justice.